Long has there been the debate of physician-assisted suicide, or PAS. Is it killing that is legal for members of higher social status, or is it providing autonomy to individuals in their last days of life? To put it simply, is it murder or mercy? There is a lot of confusion regarding the definition of physician-assisted suicide and how it is different from euthanasia. Euthanasia in the medical sense can be broken down into different subtypes. However, it can be broadly defined as the administration of lethal means by a physician to a patient in which the physician received consent from both the patient and their family in order to end the person's life in a painless way. Oftentimes, this is seen in medicine as the withholding or withdrawal of life-sustaining treatments. Examples of this would include DNRs, or do not resuscitate orders, in which medical personnel are not permitted to conduct CPR on an individual whose heart or breathing has stopped. Another example would be life support removal, which is commonly seen in individuals who have lost brain function. In either case, the medical team is directly involved in the end of the patient's life. In the case of physician-assisted suicide, however, a physician merely assists a patient to end their life if they request it. The most frequent form of PAS seen involves the prescription of a lethal medication to a patient who wishes to end their life. The subtle but important distinction between assisting and administering. Such a distinction leads to the complete legality of passive euthanasia and the much more controversial legalization of PAS. Despite the controversy surrounding PAS, there are a number of countries as well as states within the United States that have legalized physician-assisted suicide. The first country to ever legalize PAS was Switzerland in 1937, which made an important note that the physician conducting the PAS needed to prove that they had nothing to gain from the death of their patient. Much more recently, however, in 2002, Belgium and the Netherlands also moved towards legalizing PAS. Additionally, there are already 9 U.S. states that have legalized PAS, as well as the District of Columbia. Through several court cases, federal courts determined that legalization was a matter of states' rights, not the federal government. The history of PAS legality, and euthanasia for that matter, began in New York in 1828, in which the first anti-euthanasia law was created. Over 100 years later, in 1938, a euthanasia society was created who actively lobbied for PAS. Steam really picked up beginning in the 1960s, in which the, quote, right to die movement gained followers. In 1994, the Supreme Court legalized non-active euthanasia. This then pushed the state of Oregon to create the Death with Dignity Act, or the DDA, which approved PAS for patients with a prognosis of 6 months or less. In 1997, the Supreme Court followed this ruling, making PAS legal for all individuals with less than 6 months to live. From that point on, passive euthanasia became common law. However, a few more states began to accept the DDA and advocate for PAS. That number has grown to 9 states today, as well as 1 district. As PAS has been discussed and criticized, many arguments for and against have developed. A common approach uses religious arguments. However, as there was a separation of church and state long ago, and no mass decision should be based on the beliefs of specific individuals, that argument will not even be addressed here. One of the main arguments used establishes PAS as an offense to humanity. As life is priceless and should be cherished by all, willingly ending one's life is therefore devaluing life overall. As the argument goes, humans are in a community, and one person's suicide is devaluing to all life and disrespectful to everyone in the community. I first want to note that while this is not considered to be a religiously based argument, it certainly sounds like one to me. The criticism of suicide almost directly reads from religious text. Additionally, when a person ends their life, not in terms of PAS, it is not an argument of devaluing others' livelihood. It is a discussion of a person's trauma and hard-fought battles. Let us not be selfish and center ourselves in a life that is in no way affecting our own. Additionally, by framing this argument to involve other individuals, it diminishes the patient's autonomy. It boils down to be that individual's decision for their own life. Another incredibly common argument against PAS is referred to as the slippery slope argument. The idea is that the legalization of PAS would inevitably lead to active euthanasia for anyone without rhyme or reason. For instance, in the Netherlands, it has been cited that many elderly individuals come to fear that they will be forced in to physician-assisted suicide as they may be seen as difficult patients and members of society. This example and many other shortcomings of the Netherlands PAS system have become reasons against physician-assisted suicide for the United States. However, not all of the PAS systems in place in the Netherlands have been negative. As we always do, why should we not learn from others' mistakes and ensure that our new PAS system will be cognizant of such potential downfalls? Additionally, as the field of medicine and bioethics has grown, many ethical protocols have been established and approved upon. These ethical protocols are still in place and should be implemented at their fullest capacity in the case of physician-assisted suicide. Such ethical protocols include informed consent and living wills, or advance directives. While our society is far from perfect, we have come a long way in implementing these important ethical systems into all medical practices, especially physician-assisted suicide. It will inhibit many malpractices that may have occurred in the past. An additional argument against PAS states that there are potential alternatives to alleviate pain that are not as drastic. Currently, the primary medical option for individuals with difficult prognoses is palliative care or hospice. The argument continues that more time, money, and effort should be put into these resources rather than implementing a new, potentially dangerous option. Such investment in good palliative care and pain relief should be enough for most individuals. Also, there are those few cases in which the prognosis may be skewed and the patient can live on. However, while palliative care and pain relief are both excellent options that should be invested in, they still have their downfalls. Palliative care, for instance, shows interesting statistics that would prove that PAS is another viable option for interested individuals. For example, while there are 4,000 hospice agencies in the United States, limited funding and other insurance restrictions mean that many individuals do not have access to such care. Another example from the state of Oregon shows that 90% of individuals who utilize PAS are already in the hospice system. Therefore, the argument is not to choose between which care system we should invest in. It is to provide as many safe potential options for individuals as there can be. This also allows patients to use their autonomy to make decisions for themselves. It is not up to the rest of society to determine what prognosis an individual should be able to handle. It is up to the patient who is suffering. One of the most important arguments against PAS explains that the implementation of physician-assisted suicide would endanger physician integrity and the trust in the physician-patient relationship. As outlined in the example of elderly patients in Netherlands, patients may begin to feel that they are burdensome and their family and/or physician is trying to get rid of them. However, many regulations should be put in place in order to limit such possibilities. In the United Kingdom, a bill legalizing PAS for certain patients had a number of requirements in order for PAS to be a viable option for an individual. Some of the requirements are as follows. 1. The patient must be fully informed of their diagnosis, prognosis, and the process of physician-assisted suicide. 2. The patient must be informed of all alternatives to PAS. And 3. A period of 14 days must pass before PAS assistance is made, and in that time, the patient is able to fully revoke their declaration of request for PAS. Such regulations will help ensure that the patient is receiving the best and proper care and that PAS is the option for them. Another aspect of this argument involves the Hippocratic Oath that is taken by all physicians during training. The Hippocratic Oath says to, quote, first do no harm, and that in aiding a patient in death is doing harm. However, the oath also says, quote, I will never give a deadly drug to anybody who asked for it, nor will I make a suggestion to this effect. I will not give a woman an abortive remedy, end quote. This points to the fact that the oath is clearly outdated, religiously based, and patriarchal. Although physician-assisted suicide is extremely controversial, it is necessary for all patients to receive the care they deserve and possibly desire. Arguments against PAS are often religion-based or lack solid ground. Ultimately, it is the patient's decision for how to carry out their life, and no one else's beliefs should inhibit that, nor should any extraneous issues that are easily avoidable. Here are my sources. Thank you so much for watching.